I'm Janet Stemwedel. I'm sometimes known as Dr. Freeride. I am an associate professor of philosophy at San Jose State University, and I blog at Adventures in Ethics and Science.
And I am Peter Lipson. I'm an internist in Michigan. I am a clinical assistant professor of medicine at Wayne State University. I am also a teaching physician and have a private practice. I blog over at Science Blogs at scienceblogs.com/denialism, and also at sciencebasedmedicine.com.
I should mention Adventures in Ethics and Science is also part of Science Blogs, so we're neighbors.
We are neighbors.
We hear each other through the thin walls of the blogosphere.
Excellent.
And what are we going to be talking about today?
We both have an interest in ethics, although from slightly different perspectives.
Absolutely, and I mostly talk to people who are trying to be scientists when they grow up, or who are already grown-up scientists, about what kind of ethics helps them do their job. And so I'm really excited to be talking to you tonight about how ethical matters look on the practicing physician side of the fence.
Yeah. Sometimes grim and sometimes great. So,
because physicians are a little bit like scientists, but then they've got this whole other therapeutic thing going on.
Yeah, it's an interesting position. I mean, some physicians are explicitly scientists, and then the rest of us are clinicians, and our work is science-based, but it isn't the practice of science. I guess you would call it the practical implementation of science, but it's an odd place to be in sometimes.
Well, and even the physician scientists are, they may see their role when they're doing research as primarily doing science, making scientific knowledge, but they can't really switch off their ethical duties as physicians.
No, and
once
of
you
course
put those on,
that
it's like a tattoo.
Yeah, and that opens a whole other issue of, do you ever take off your white coat? I mean, once you're a physician, are you a physician everywhere and all the time? And that's maybe an issue for another discussion, but
or maybe a little bit for this one, because sometimes there's an uneasy fit between people's professional duties and commitments and people's personal values.
Yeah, and that actually, something else I was thinking about earlier, maybe we'll get to this a little bit later, is the latest Institute of Medicine report about resident work hours. And I'm just going to make a little note, and maybe I can pick your brain on that as an ethicist in a little bit. But something you and I had talked about, and I think, I know I've blogged about it, and I think you have as well, is this whole idea of conscience clauses and the Health and Human Services rules that the Bush administration is trying to get through under the wire here. Basically, what this order would do is allow healthcare providers, and that's a very broadly defined term, including pharmacists, physicians, nurses, to refuse to provide services that they don't feel ethically or morally comfortable with without any consequence to them.
Right, and these have been somewhat controversial rules, or some would describe them as an escape hatch, a hatch that lets you weasel out of doing what the person who's in a therapeutic relationship with you understands your job to be. And I guess, I'm sort of wondering from the point of view, I have a strong view as someone who seeks medical care and also as someone who sort of sees ethics wrapped around us all the time in our interactions with other people in the world. But I'm especially curious as to how, when physicians are being trained, how matters like what's the line between your own, personal values and what you're getting into when you take on this job. How is that presented to medical students?
Yeah, well, that's a really good question, because I don't know that there's a single answer. I'm somewhat involved in medical education still, and I have to say that based on my own experiences, most of these things, while most medical schools will certainly teach ethics explicitly and, pass out a copy of Beauchamp and Childress and discuss some of the basic medical ethical principles. It really isn't until you are working with actual patients that you see what the ethical problems are day to day. And I think one of my problems with conscience clauses or this whole issue is that it really removes the focus of the ethical spotlight from the patient, where I think it belongs, as the sort of supplicant, if you will, to the physician who, while they have an ethical stake in the relationship, it sort of says that for some reason the physician's beliefs are more important than the person who's seeking their help.
Okay, I think it's really interesting that you describe the patient in this relationship as the supplicant, because that really does sort of emphasize that this is a relationship where there's a power disparity. This is a relationship
Absolutely.
where, the reason you're seeking the medical care that you are from the healthcare provider is because they have powers that you do not. You need them. You can't
Exactly. There's always going to be a power
do it
differential.
yourself.
Yeah, and there will always, no matter how much we wish to diminish the influence of paternalism, there's always going to be that relationship, because even if you are a professor of medicine at a huge university, when you go to the doctor's office, you're a patient, and you're seeking someone's advice, and you're putting yourself in their hands, and you are reducing your level of power in that relationship inherently.
And this is clearly why they make you wear the paper gown, right, while you're waiting to remind you that you're the powerless one in the relationship.
Not
There's
all
no
of us
other
do
reason.
that. Some of us actually have gotten into near fisticuffs with our colleagues about the proper nature of that. So.
Anyway, okay, paper gowns aside, so given sort of the unequal power between the healthcare seeker and the healthcare provider, the healthcare provider, I guess, is coming into this relationship saying, here are my needs, you're the person who I understand can help me meet those needs. If the healthcare provider says, well, but helping you meet those needs would somehow violate an ethical commitment I have, helping you, get the morning after pill is going against my conscience. How should the physician or the pharmacist or the healthcare provider deal with that, do you think?
Yeah, and that's, unfortunately, some of these questions need to be asked before you apply to pharmacy school or medical school, and that's not always done, or from my more cynical perspective, I think sometimes that is done, and somebody says, I'm going to go in there and stir things up. Mm-hmm. But, sometimes you can pick extreme, as you know, as an ethicist, you can pick extreme ethical situations. For instance, if a patient were to come to me and say, I need you to help me end my life. This is sort of that edge. And that's not the everyday situation. And we can sit there and talk about that kind of situation all day, which might teach us some things, but I think more important is to look at the real situation every day. When you or your significant other goes to the drugstore to pick up your birth control pills, and the pharmacist says, I just can't do that. It's not my thing. Mm-hmm. I think that's an everyday situation, and I think that there are some important principles there. One is the one we've talked about, which is that power differential. You're basically abusing that relationship as far as I'm concerned, and there's other issues too. I don't know what you think. But.
Sure. Well, I mean, it seems to me at the very least, on the one hand, I wouldn't want to say because of the therapeutic relationship, because of the power disparity, that the patient, the person seeking health care, ought to be able to make the provider do anything. I mean, that seems like it would be too much. On the other hand, it seems like there's at the minimum an obligation for the provider to treat the person seeking health care with a certain kind of respect that involves, communicating really clearly and openly and saying, here's the situation, here's what you're asking me, here's why I think I can't provide it for you, here are the other options that I will, lay open for you to avail yourself of. So this is, I don't know that I have as much of a concern, If it's at the Walgreens, there's one pharmacist who feels ooky distributing Plan B, but they have all the other pharmacists who are okay with it on call, so that no one is put in a situation where they can't get the medical care they're seeking.
Yeah, but in addition to that, I think I don't think that the patient or the customer, if it's in a pharmacy, should really be subjected to the objections of the person distributing the medication.
Absolutely.
So that if
they're not coming for a sermon.
Right. If because that can have adverse health consequences. If there's somebody working at the pharmacy who objects, they shouldn't be put in the front, probably. I mean, a patient, especially Plan B, is a you have a narrow time in which you can successfully use the medication.
Right, and it's not hard to find stories of people who have had that clock run down to zero by a care provider who's jerking them around, who knew that there's this limited window of time, and that's clearly unethical. I mean, that's just, basically it's deceiving a fellow human being, treating them as if they're not allowed to, autonomously exercise their own will. And if it's legal, and if in fact it's recognized by your profession as something that's in the range of things you ought to be providing, or at least that it's not inappropriate for someone seeking the health care to be seeking, then being an obstruction there is a problem.
Yeah, and I think if it's a procedure or medication that is part of the standard of care, I think to me at least, it's a no-brainer, except for one or two things. When you start getting into these extreme areas like euthanasia, which I think is a whole other discussion for another time, that's different. But when we're talking about widely accepted practices, birth control pills, Plan B, gee, it's kind of strange. All these affect women disproportionately. Anyway,
why would that be?
I don't
like maybe we have some anxiety about, maybe this is what it comes down to, is possibly some of the people with these objections that they want cover from a conscience clause to take care of may not feel fully connected to a moral an ethical community that includes women as full members.
Yeah,
that's just a hypothesis. I would need to study that for sure, but if I had money to bet, I'd be betting on that.
That'd be nice. That'd be nice to try to figure out. I have my preconceived notions of what you'd find, but there's certain things that something you mentioned just about 3 minutes ago. You mentioned that you certainly can't force a provider into doing anything, and I think that's important to mention. For instance, many physicians and nurses who I've spoken to, colleagues and friends, who are uncomfortable with various procedures, you can't coerce a physician to providing a procedure. Right? You can't tell me to remove an appendix. I don't know how to remove an appendix. But focusing on something that I actually do know how to do, you can't tell me that I have to treat a particular person's blood pressure a particular way. There is some. I have to bring my professional and personal beliefs to bear to a certain extent, but I think when you cross that line into coercion that isn't congruent with the patient's needs, and that's of course a really, really gray area again. Anytime I open my mouth with a patient in the room, I'm coercing someone, more or less, and because of that power differential. And usually I like to think I use my powers for good and not evil, but that's not a given, and that's why we actually have these conversations.
Right, and this is another thing I was hoping we could talk about, which is that there's this idea in the ethics of, certainly at least in the ethics of research with human subjects, but I think it's also a pretty standard part of medical ethics, that you're supposed to respect the human that you're dealing with as a person. You're supposed to respect their autonomy. You're not supposed to be paternalistic. And as you point out, once you've got a differential in power and also in knowledge, and of course knowledge is power in a certain kind of way, it's hard to say, this patient can exercise full autonomy without, being at least a little bit coerced. And it may also be hard to say, I want this patient who I know understands what's going on less well in some ways than I do. It's hard to want to let them be autonomous. I mean, it would be like letting my kids be fully autonomous. At this point, it's my job to prevent that so that they can grow up to be fully autonomous human beings.
Yeah, I mean, and that's definitely, you're always walking a fine line, and hopefully you're thinking about what you're doing when you're doing it as a clinician. You're guiding people toward decision. Nobody wants a colonoscopy, right? I mean, hopefully.
Yeah.
But
the internet will probably
somehow
help us find the rare exceptions who do.
but somehow you've got to convince a 50-year-old that they want to have, several yards of fiber optic scope, into their colon. And obviously there's a good reason for it. You're trying to prevent colon cancer, but it's going to be an uncomfortable procedure to a certain extent, and there's going to be a certain, depending on the patient, a certain amount of humility that's destroyed. But you do coerce them because you scare them. You say, well, if we don't do this, there's a chance you could get a colon cancer that we could have prevented and die of it, and it's going to be your fault. Mm-hmm. And that's.
I mean, sometimes information is scary to the extent that having more information helps us make better decisions. Sometimes some of that information is going to present scary possibilities, and maybe this is one of those places where medicine gets especially hard. It's pretty clear you're not dealing with nice, neat, deterministic, well-understood, fully characterized systems. You're dealing with human health. And these are people who are running out there in the world. They're not raised in standardized conditions in a lab. So you're talking a lot about frequencies and probabilities with people who are notorious, all people, humans, are notoriously bad at wrapping their heads and their intuitions around frequencies and probabilities. And you're trying to say, well, we don't know what the outcome is. Here's the range of possibilities. Which one should you think is going to happen? How should that guide your actions? And by the way, are you the kind of person who plays the lottery? Because, that right there might tell me something about your grasp of how this stuff works.
And that's exactly, when you talk about, you've written before about is medicine an art or a science? And the answer is fish. The art comes in trying to read a person correctly, trying to interpret an interpersonal interaction between a professional and the other person, and trying to decide, what does this person need from me here? And, do they need me to be a little more paternalistic? Do they want to feel like they're making all the choices? Do they want me to just shut up and go away? And that, I think, is where the art comes in. The recommendations themselves are hopefully science-based. We know that, or we have a pretty good idea at least, that if you screen people over 50 with colonoscopies for colon cancer, you can prevent early death. So, we use that data, but then, where to go from there and how to talk with another person is, it makes me think about people who do research, like the people who you deal with every day and some of the people we write with. When you have them do all the paperwork, you put your protocol through an IRB and Human Subjects Committee, and you have some. It seems to me at least some fairly clear lines and people can drop out of a study. People can't really drop out of medicine, out of their health.
Yeah, well, I mean, some people do, but
they do. Yeah,
you don't necessarily want that. But I guess in some ways maybe that's. Yeah, well, okay, I've got a bunch of ideas bumping into each other right now. So one kind of thing is, the art versus science thing. I've run into a few physicians who I think are more convinced that they're scientists than I am convinced that they are. And not just because I have a PhD in a science, but because I'm not inclined to take places where the results are equivocal and say, well, your hunch, Dr. Guy, is necessarily the way things are. If the results...
Yeah, all of our studies are N equals 1.
Right.
And that doesn't make for the best science in the world. So.
Although in some ways, part of the art of being a good physician sometimes might be coming clean about the uncertainties. I this summer had my first mammogram and, of course, blogged it because, crazy blogger than I am, that's the kind of thing I do. And one of the things I found striking was the information I was given beforehand and then, after the fact about, well, here's what we know about the effectiveness of screening mammography in your age group. And it's not obvious how big an impact it has. And there's different schools of thought about how frequently at your age you ought to be having them. And I actually, rather than being freaked out and saying, oh my God, they don't know what the hell they're doing here, I thought, this is nice. They're actually treating me like an adult and they're sharing with me what they know. That seemed like a great way to respect me as a person and to respect my ability to participate in the choices around my health care. And to sort of say, as it becomes more clear from the research, obviously, we're going to keep you in the loop because that's what we do in this medical practice.
I think that there's definitely a split in medicine. There are definitely doctors who think it's okay to say I don't know and doctors who think it's not okay to say that. And certainly there are situations where it's just not okay. If you're a surgeon and somebody says, do you want me to cut this, thing, you can't say I don't know.
Right.
Somebody's filleted open in front of you. You have to make a decision. But, quite frequently, that's one of the things I do quite a bit. I try to tell my patients, look, I don't know everything. We're going to figure this out together. I do happen to know more than you on this, but, when you ask me this question, I don't know. I don't know the answer, and I don't know if anybody knows the answer, but we'll try to make a good decision. And that's not everybody's comfortable with that kind of uncertainty.
Well, but that's the universe we're living in. If you want to hear a story that we know more than we actually do, I think you're looking for a different kind of medical care provider than the kind who's playing by the ethical rules that ours are supposed to be playing by.
Yeah, you know what? That brings up an interesting point, and that is, if your patient really wants an answer and you just don't have one, is it okay to make one up? I have my own opinion, and I suspect that it's not uncommon for people to make up an answer, and I think that there are different situations. If, when somebody has, say irritable bowel syndrome, a disorder that's very common and yet we don't understand it very well, some patients aren't comfortable with hearing, I don't know what's causing your pain. I have a name for it, I don't know what's causing it.
Uh-huh.
And I think there's probably physicians who will say, well, blah, 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 blah. Let's make up something that sounds good and it's at least physiologically possible. Throw in a couple of words like serotonin receptors, whatever. That you may have caused someone to feel better because you're acknowledging that you've heard what they need and what they say, but is it okay to sort of toss that subtle layer of deception?
Well, and here we may be sort of treading into placebo effect territory.
Yes.
And I think I've mentioned before, actually, that since, what I've seen of the research suggests that there is something like a placebo effect, I would like to be able to go to my local drugstore and buy, of course, generic placebos for what ails me. If I believe.
Well, I don't know. The generic placebo isn't going to work all that well. You got to get the gold-plated placebo.
Yeah, not if you're a chemist. If you're a chemist who understands it's the same active ingredient, I think the cheapo placebos work well too, and that's important.
Yeah.
When you're a chemist.
And you and I have both. You and I have both written a lot about placebos from different perspectives. Yours sort of more how they're used in clinical trials, and me sort of. Well, no, you've actually written more on some clinical stuff as well, but, I come down on a funny side on the placebo thing because I sort of suspect that there might not really be such a thing as placebo as, let me rephrase that. I don't think that there's such a thing as a placebo treatment.
Mm-hmm.
I think that there's such a thing as a placebo effect, something that we call changes that we happen to observe when somebody is being treated in the setting of a study.
Uh-huh.
But I'm not so sure, and a lot of doctors are going to totally come down hard on me on this, I'm not so sure that there really is a placebo treatment as such.
So you think it may be the people thinking they're seeing this effect are expecting to see it, and that's why they're seeing it, or the people being...
I think people are measuring whatever kind of other effects and background noise, etc. And
so just random fluctuations are counting as effects.
Yeah, and you know, of course, you can sort of try to parse that out a little further mathematically, but I'm not so. And actually, I should preface this by saying everybody who's ever worked with a patient has seen somebody quote respond to a placebo,
Mm-hmm.
but I'm not so sure that you can actually prescribe one and have any reasonable expectation of it having an effect. I don't think it's predictable.
Right. Well, maybe.
I don't think you can.
And maybe they're like depression drugs. Maybe you need to try 3 or 4 before you get the right placebo to give the effect.
Well, I got to tell you, if somebody comes into me with a severe upper respiratory tract infection, by the time I get to the 3rd or 4th placebo, I have cured them.
Yeah, it's you. It's not time.
You know, and exactly, and I think that's one of the things we sometimes measure. Most diseases are self-limited in one way or another. You either get better or you die from it. And, you know, you can throw things at it all day, but if you haven't looked at it in a controlled trial to see what really affects it, it's easy to start to think that you have some sort of magical power to affect an illness, when in fact you're just witnessing nature.
Sure. And, well, I guess, and some of those controlled trials get really interesting. I was at a conference in November where I heard a talk about difficulties in, you know, talking about the placebo, or not. It was not so much about placebo effect, but about double-blind trials. Difficulty in setting them up and having them be really meaningful. Part of that was because apparently subjects in some of these trials are pretty good at sussing out whether they're in the treatment group or in the control group.
Oh yeah, people are clever monkeys. I mean, you know,
almost as clever as actual
so
monkeys.
Easy. Yeah, I mean, it's really they're pretty smart.
Yeah, so it turns out a placebo with a side effect that seems a lot like one of the potential side effects you've been warned about in the active agent that is being tested in the treatment group. That's going to have people concluding maybe I'm in the treatment group and not the control group, and maybe I should be feeling better, and maybe I am feeling better now that I think I should be feeling better. And for me as an ethicist, I sort of sit back and say, well, wait a minute, what about, you know, is it ethical to expose the people in the control group to side effects that when there's no expectation of the effect, right? Are you asking them to take on a risk with no counterbalancing expectation of a benefit? And is a placebo effect
well,
enough?
Except that maybe the expectation of benefit is that they might be in the treatment group,
Mm-hmm.
as far as they know, and so they have. You know, they have if they're experiencing a side effect, as far as they know, it might be a side effect of whatever the placebo is, or it might be a side effect of the treatment.
Sure.
So, you know,
of course, the standard way to think of it, though, is if I'm in the control group, it's not going to be any worse than if I did nothing at all. It's not going to be any worse than if I didn't participate in this research in the first place. Whereas if you're in the control group and you know, it's not no worse than participating, but suddenly you've got dry mouth and you're vomiting and your eyes are swelling up or something, and it's the placebo. Maybe that's more harm than it's ethical to expose someone to just to get clean data. And I think this is where doing science with human beings as the subject gets really tricky compared to, you know, just taking a bottle of reagent off the shelf and some beakers and some Erlenmeyer flasks. You don't have to, you know, treat them with any special ethical regard aside from not pouring them into the municipal wastewater. You just, you know, they're chemicals. They don't have ethical duties that bind us to them. Other human beings, even if they're the kinds of things we need to move around in our experiments to make the knowledge we think is important to make, we've got special duties to them.
Yeah. Yeah, and that actually brings up another topic that both of us have discussed before, and that is when you have a treatment group that's receiving a rather implausible treatment, how ethical is it to conduct the study at all? And we've talked about this a lot over at sciencebasedmedicine.com with some of the folks over there and the National Centers for Complementary Alternative Medicine, where some of the things that they do are testing very implausible ideas in order to sort of clear the error. I'm pretty sure, didn't you write about some of the chelation studies?
Yeah, there was the one chelation study that the research was stopped partway through, and I guess some people were surprised that it even got off the ground in the first place, where the hypothesis was that maybe the chelation therapy was going to, I think it was around autism, that it was going to lead to improvements in autistic children. And I guess part of the rationale was there were a good number of doctors who were already giving their patients these chelation agents.
And that's why I run into problems. And this is where I think being a responsible clinician interfaces well with the scientific community. If I have a patient come to me and they're being recruited for a study, say, and they ask me what I think of it, I think I have a responsibility to my patient to say, you know what, this study is just wrong. The premise is so improbable, and the thought that you or society could derive any benefit from your participation is so unlikely that not only shouldn't you be doing it, but we should probably talk about it out loud.
Right, and I, on the one hand, I could actually imagine that there might be a certain population, and it probably wouldn't be, all of the population you'd want to reach, who might really need to see a double-blind trial that said the chelation doesn't help. Who, in the absence of some kind of trial like that...
Yeah, but boy, is that a tough one.
Yeah, well, but...
It is.
So...
It's tough because that's what they, people do want to see those studies. I mean,
that's where knowledge comes from, as far as we know. And so there's going to be a certain population of people who says, until you've tried it, if all we've got is anecdotes, we actually don't know one way or another. And they're going to say, let's find out.
And there seems to be a certain amount of intersection between the sets of people who would like us to see us prove that negative, and people who will refuse to abandon that belief no matter how many negative trials
Absolutely.
we get.
And this is, of course, the tricky thing is if you ask for a double-blind trial, and if you agree that the setup of the trial is appropriate at the beginning, you got to be ready to back down from even the hypothesis that seems most likely to you. I guess the tricky thing, maybe with these chelation trials, there was good sort of what you might consider circumstantial evidence beforehand that probably this wasn't going to help because none of these kids were displaying high levels of mercury or other heavy metals in their blood.
Yeah, let me give a little bit of the
Sure.
background, since autism is a pervasive developmental disorder that probably represents it's a label that probably represents a number of different problems, but the cause isn't known of most of it. In most cases of autism, there is no known cause, and it generally manifests itself during early childhood, which makes it even scarier. And these kids can be, but not always, very significantly emotionally, psychologically, cognitively disabled. The symptoms tend to show up around the same time that children are undergoing, their usual routine childhood vaccines. Of course, it also happens at the same time they're learning to walk, the same time, a lot of things happen at that time in your life. But vaccines are an external factor, I guess. And since we don't have people in large numbers dropping dead of vaccine-preventable diseases, there's a certain segment of the population that has taken up this belief that vaccines somehow are causally involved in autism, and then there are a few folks whose names I don't even feel like mentioning because it'll make me all angry, that came up with this hypothesis that, well, maybe it's the mercury compounds in some of these vaccines that are causing this. Mercury, after all, certain mercury compounds are known as neurotoxins. Therefore, if you're putting them in a body, they must somehow be bad, et cetera, et cetera, et cetera. Now, these hypotheses have been tested time and time again by very, very good studies, different kinds of studies as well, and been roundly shown to be, just not valid. Vaccines do not cause autism. Heavy metal poisoning does not cause autism. Vaccines do not cause heavy metal poisoning. None of this stuff exists. And when you look at some of these folks, they don't have elevated levels of heavy metals if they're sent to a reputable lab. So you have these doctors who set up their clinics where they chelate people. Chelation is you inject chemicals into the bloodstream, and it removes heavy metals, and that can be very useful for people who actually have heavy metal poisoning. So,
and it's very cool chemistry too. The chelating compounds
it's
wrap
so
around
cool. It's
like
also
a cage and pull them out, and it's beautiful. The molecular models. And
it's great. Unfortunately, sometimes they can grab a whole lot of calcium out of the way if you don't do it quite right. And people have been known to be killed by this therapy. This completely unnecessary therapy.
And actually,
and so,
if I'm recalling the trial we were talking about correctly, they actually took steps like calcium supplementation, so in some ways the chelation they were studying, they were doing it in much safer circumstances than you imagine would be happening in the offices where...
In that particular study, there's another one, I can't remember which one it is right now, but there's another one that's being run a little bit shadier, but... the problem with this out in the community, meaning not in the lab, is physicians of any particular specialty, because once you're a physician, you can practice anything you want, you just might not be good at it. They are telling people they have elevated heavy metal levels, sending things to a lab that will confirm it, independent of what the truth is, and then chelating people. And of course, if you put a chelating agent into someone, you're going to remove something. You're going to pee out some heavy metals, and so they look at that as proof of effect, and of course it's not. So these trials have been designed on this false premise of autism caused by heavy metal poisoning, and because chelation can treat heavy metal poisoning, it might treat autism, and because the whole premise itself is broken, it makes me feel that the trials themselves are unethical. But as you mentioned, there may be the segment of the population who need to see that evidence. Although I'm not. You're
not persuaded that as many people are gonna take the evidence and say, okay, that pushes me over to this other place than where I was, and now I'm willing to look at other options instead. You think?
Yeah, I think I may be a mean and cruel cynic, but yeah.
You've probably seen more people who are clinging to whatever hope there is in the face of a great deal of uncertainty. It's a lot easier to look at things in the abstract, to say, given these choices, how might people fall? I guess the thing that I think makes this relevant, though, to more than just where our state of understanding autism is right now, and where sort of lay people's understanding of autism is right now, and what kind of hope they're going to cling to if there's nothing else available, is for most of the knowledge we have, there was a point in time where we knew a whole lot less, and we still had to make good decisions, and this is ultimately why we need to run clinical trials, and why it is so hard to give the subjects of those trials as much protection as you might want to, because if you fully understand what all the risks and benefits are of participation, you already have the knowledge, and running the research would be an unnecessary duplication. It would be exposing humans to risks that are not strictly necessary to build more knowledge. In the absence of the knowledge, you're just guessing at what the risks are, and you're giving them the best guesses you've got, but there's a good chance you're wrong.
I have a question for you as somebody who knows a lot more about this than I do. When let's say I'm enrolling in a trial as a subject, and it's maybe one of these trials where I don't think I'm going to personally benefit that much. I have a terminal disease, but I see that there's a societal benefit to my participation.
Right. So that would be a non-therapeutic trial.
What's the ethics surrounding that?
What ethics govern that? Well, there's still a strong obligation to the welfare of the human subject. Strictly speaking, it's not exactly a therapeutic relationship. If it's sort of, maybe the early stages on drug trials where you're just trying to figure out what kind of dose can I give to someone and not make them sick or dead.
Right.
You've got to be clear with the patient that or the subject. See, again, I think if you're a physician scientist, you can't fully turn off the physician obligations, and it's not going to be the case that the subject is going to see you as other than a doctor who is responsible in sort of physician-y ways for their well-being. But there's still certain kinds of lines you can't cross. You're not allowed to expose the subject to an amount of risk that's going to, permanently damage them or, increase their risk of death over and above what it was by a certain threshold. And I guess the IRBs have to hash this out. I know some bioethicists actually worry about whether it's possible to get good consent from human subjects in non-therapeutic trials. Sort of the standard story is if it's, sort of an early phase trial of potentially useful cancer drugs, as soon as you say cancer, the patient is just going to hear wah, 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 for most of the rest of the conversation until you say, research study, and then they might say, oh, something that could help me. So I think even if the researchers make a big deal out of sitting them down and saying, but look, we're not at the stage where the knowledge is going to be in any kind of shape to save you. That this is strictly going to be for the good.
That's not what's heard. That's just not what's. Yeah, it's a clinical fact. The Peanuts adult voice. The wah, 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 wah. That is, after you say the C word, that is all they hear, and it is. I don't think I'd have to agree that in that situation, if you're sitting in that room, you're not going to be able to really obtain truly informed consent, because honestly, when I see, if they're in the oncologist's office and they come to see me again as their primary care physician to give me the news, etc., I'm going to have talked to the oncologist. I'm going to know what's going on, and the patient's going to say, "Hi, how you doing?" And I'm going to say, "Well, what do you think about this whole cancer thing?" And they're going to be like, "Cancer?
Yeah,
cancer." And they're not. They might not even remember that they have cancer at that point. It's just very difficult, despite the fact that, they may have a cancer that isn't going to negatively affect their quality or quantity of life compared to, say, if I told them they had class 4 heart failure, that would be devastating to somebody with the knowledge to know that. But that word cancer has a special power, and it really obliterates any ability to have a conversation once you say it.
Yeah, I don't know. Maybe someday we'll know enough about good ways to treat cancer that will change.
Well, we're getting there, certainly. We're curing a whole lot of cancers. We're preventing and we're curing, and even more so, we're treating successfully, if not curing, a whole lot of cancers that a very short time ago weren't treatable, or that were basically a rapid and painful death sentence. So we've made huge strides in that area, but still that's got a certain power.
Right. There's a flip side there too, to sort of our increasing prowess at dealing with different diseases and health issues, which is, I worry that sometimes physicians and physician scientists feel like maybe it's their job to cure mortality. And
Yeah.
that might be a bad idea. I mean, I think in some ways that's not only sort of changing the options that physicians are happy putting in front of their patients as reasonable ones to pursue. I think it's also putting a lot of pressure on physicians.
Yeah, well, we generally have an expectation in this country of immortality.
Uh-huh. Well, unless
you
we've
know.
taken care of a family member who's lived more years than they wanted to live, and they let you know it
Yeah.
the last several. And then you start eating more butter. I'm not kidding about that. It's not me, but I have family members who are eating more butter and more chocolate because, yeah, they don't want to repeat what earlier generations went through.
Yeah, it's there are some, and then I think that there are some. I hesitate to bring this up because I will probably run out of time, but with the change of administration and the economic situation the way it is, there are going to be some decisions to be made at a much higher pay grade than mine about what we are going to study and what we are going to fund.
Right. Well, and there's already decisions being made about, not just what kind of knowledge we're building, but what we're prepared to do with that knowledge and who's going to benefit from what we know. If we, the way our insurance system stands right now, it's not like everyone has access to all the treatments we know about that are effective for all the different things that we come down with.
Yeah. There are huge... well, I mean, we could get into that forever. Various utilitarian arguments versus, But I'm actually going to try to put a podcast together for next week with a libertarian colleague of mine. Which would be,
that should be fun.
A little interesting. Yeah. But there really is one of the things I see every day is people, and literally every day, especially now, people making individual decisions about life or death issues based on economics. I will tell somebody, you need to go to the emergency room. This could be a life-threatening condition. And they'll say, geez, my insurance kicks in next week. I'm going to wait.
Yeah.
And, as a physician and not a policymaker, how can I, if I tell them no, I mean, I don't know that they have a life-threatening condition. I suspect it. It's my judgment. How do I tell them to put themselves at enormous financial risk on the one hand versus enormous physical risk on the other?
Right. Because the financial risk can cascade into different kinds of health risks down the road.
Yeah, and this is, and at least in my part of the country, every single one of us in practice here is seeing this every single day. Much more so in the last several months. It's really, it's not a matter of clinical trials. It's not a matter of the ethics of being in the exam. It's a matter of, do I coerce this person right now into getting care that they may never be able to pay for and may end up, in worse financial straits, or do I, allow them to wiggle out of it, potentially putting them at risk for death?
Right, and this is one of those issues that comes up, I think, in research too. Definitely in the trials of AIDS drugs, looking at maternal transmission of HIV in sub-Saharan Africa. There was a question about, was it ethical to be conducting placebo-controlled trials when there were drugs available that were known to have some efficacy against HIV? And the question was, if the people in the control group stand a good chance of getting sick with this illness that right now does pretty nasty things to people, how can you possibly, you've got obligations to the people in the control group, how can you possibly let this go forward? And part of the response was, well, but the situation is such that the local standard of care does not allow the kinds of treatments that people in wealthy communities around San Francisco may be able to avail themselves of.
Yeah. And then the question becomes, which ethics are universal?
Right. Well, and there were some other arguments that were maybe more from the point of view of what kinds of therapies can you realistically deliver if you're not willing to swoop in and impose, suddenly create a medical infrastructure where there is none, suddenly have,
Right.
Nurses and physician's assistants with wristwatches following patients around administering multiple doses of things through their day. If you can't support that, how can what sense does it make to say, oh, we found a therapy that could be useful, except it doesn't in any way connect to the realities of your life? Yeah. And that might be...
Yeah. Sort of like dropping 20 ventilators in an isolated village without electricity.
Right, yeah. So it's a tough question, because I think in some ways we think knowledge is always going to let us solve the problem, and it's more than just a piece of knowledge that lets medicine go forward. It's sort of how knowledge interacts with the other features of individuals and communities and the lives we're living.
Yeah. And we're going to have a very difficult time over the next couple of years in the States dealing with the fact that our culture is very, very individually oriented when it comes to making ethical decisions, and yet we're going to have to make some high-level societal decisions about how to distribute healthcare resources, and we're going to have to make them very soon.
Yeah. But in some ways, I don't know, moving to more of a community way of thinking about the ethics might end up addressing some of these worries about things we talked about earlier, like conscience clauses, where people want to say, well, my ethics are the highway if you're coming here to my pharmacy or to my practice. If we start actually understanding that we are accountable to each other, even if we don't always see the world exactly the same way, even if we do agree on...
Well, and that's why I think...
Even agreeing on the facts, we might value different things. And that's, I think, someplace where sometimes it's hard for both patients and physicians to back down and to say, we're not disagreeing about the facts here, we're not disagreeing about the probabilities, we're disagreeing about which of these outcomes we could pursue is desirable.
Well, and I think that's where learning to have explicit conversations about ethics comes in handy, and that's why probably more of my colleagues, including myself, need to learn more about ethics, because if you can actually, when we talk about various medical ethical principles, paternalism, autonomy, et cetera, non-maleficence, these things are great, but they're not tools. They're a template. They're a template on which to hang a discussion, and when you explicitly bring these ethical ideas out, and this is one thing I see sometimes in the hospital, not as much anymore, but if there's a particularly difficult ethical problem, let's say that there's somebody who's half dead on a ventilator or all dead on a ventilator and the family doesn't want to let go, and somebody will say, let's get an ethics council. Mm-hmm. And in their mind, that means the ethics committee will swoop in and achieve the outcome that the care team wants.
Right. And they're supposed to be like, the hazmat people in the bunny suits to come in and clean up the mess. And that's totally not how ethics works.
That's not how ethics works, and I think people forget that. They don't come in and enforce anybody's, they come in and they literally stand there at the board, at the dry erase board, and write down ethical principles and say, how are we, and then they talk with all the parties involved, and they listen.
Yeah.
And they try to, and it's a very different process, I think, than people think it is. And I think people...
I want to disagree with you when you say, these ethical principles aren't tools. I think they are tools, but they're tools to do something different maybe than we sometimes try to do. We're not...
I guess the more proper terminology would be they're not rules.
Right. Well, I think what they are is they're sort of tools in a toolkit for a certain kind of problem solving. And the problem solving is not how do I get the other person to where I want them to be. It's how do I look at my commitments and their commitments, and my duties and their duties, and my obligations and their obligations, and how do we find the best place to get to together, and how do we do it reasoning through the options together. And that's wicked hard. I mean, that involves actually always seeing other human beings as human beings and not just obstacles in your way. And, goodness knows you get behind the wheel of a car and that can go right out the window. But ultimately, that's what being ethical is about, and that's why, physicians earn every penny that they're getting paid, because doing it right, and you guys should get more pennies too. Doing it right is really seriously hard work. You can't, sort of do the calculation once, write the result on a little card in your wallet, and you've got it for all time. It's always going to change depending on what the situation you're put into is, and what the values of the people you're dealing with are, and where they want to go, and listening to them and trying to get them to listen to you, trying to explain to them why it is you think the course of action you're proposing is better than maybe the one they seem to be valuing, and then finding where you end up together.
It's a hell of a lot of fun.
It can be, yeah. But
I mean, it may be stressful, but I don't, I don't obviously work on the research end, so I don't have that type of experience. But at least in the clinical setting, it's draining, but it's a lot of fun to do that. I try to convince my residents of that, sometimes not always successfully.
Right. Well, I mean, my big thing that I try to convey to, not just future physician scientists, but future scientists, is the reason to be ethical isn't because some busybody from the philosophy department is hovering over your shoulder, or some busybody from the IRB or the IACUC or the ethics board. The reason to be ethical is it helps you do your job better. It helps you to live the values that organize the activity that you're a part of by virtue of being a scientist or being a physician.
Yeah.
So they're not stupid rules. They're actually, helpful tools.
Well, and thankfully, most of the people we work with every day aren't stupid too, and I think most of them eventually come to realize that when we start boring them with our ethical conversations.
Yeah, well, you'd rather have a physician who's had some of these ethical conversations or spent a little time pondering it than some physician who hasn't. I should think.
Yeah, I like many conversations in medicine, I like to tell my residents, my students, my patients that it's better to have these conversations before you actually need to.
Mm-hmm. I mean, like any kind of problem solving, you don't want to work your first sample problem, when you're taking the final exam. Mm-hmm. You kind of want to think it out. And the other thing, too, is ethical reasoning in some ways is a lot like scientific reasoning in that it benefits from taking account of what other people think the best solution might be. It benefits from talking it out. You don't want to be going on your gut. You want to be going on something like an objective decision. And the best way to get objectivity is to get some other people to cast their eyes on the problem and weigh in on it.
Well, I'm hoping that people who watch our little dialogue here will take away, at least from my perspective, a couple things. One, that there are physicians and scientists and ethicists out there who actually are thinking about these things every day. And two, that there's no reason that everybody else can't think about these things every day. Absolutely.
I think it's the responsibility of a patient to sort of understand what their role is in the relationship between themselves and the healthcare providers, and that they've got responsibilities too, as well as rights.
Yeah,
and one of those responsibilities is listening.
Yeah, not always easy, but...
Well, hey, nothing worthwhile is all the time, so...
Yeah, people say that.
Mostly their parents, aren't they?
Yeah, exactly what I was thinking. Oh, and I'm becoming them.
Yeah.
Well, this was terrific talking to you.
Well, I'm glad we were able to do this, and maybe we'll have to do this again, because I think we probably could have filled 2 or 3 more hours with good.
Quite easily, and hopefully there are a few people out there who will find this as fascinating as you and I did.
Absolutely. Well, thanks. This has been a great conversation, and
all right,
we'll do it again soon.
Great. Well, I'm going to go watch the snowfall. So.
Yeah, I'll think about snow in an abstract way that one does in California.
Excellent.
Alrighty.
All right, I'll talk to you later.
Yep. Okay, I'm hitting stop.